Okay, so welcome to USMLE Crash Course. This is a very high-yield broadcast again. It's based on all your NBME concepts and the previous USMLE exams concept, and it's kind of hitting both of the exam. Mostly it's for Step 2 CK. So I will be entailing some of the questions here, and you kind of have to. They want you to know this. I will be giving you some bullet points here, and what they want you to pick up from the question is those bullet points for your questions, because the question stem seems to be too long, and that's why these bullet points will be helping you a lot when you are doing these exams, right? So first thing first. So if you have a patient who is a traveler and get a diarrhea, watery diarrhea or brown diarrhea, green diarrhea, it's usually self-limiting. So what is that? That is actually traveler's diarrhea. And traveler's diarrhea is usually, associated with what? E. coli. The toxic component of that leads to traveler's diarrhea, right? If you get a bloody diarrhea, and in a whole question stem, they give you a history of poultry consumption as well. So what will be you thinking here? You will be thinking two things. One is Campylobacter jejuni, and second thing is Salmonella. Salmonella and Campylobacter both can cause bloody diarrhea with poultry consumption. Campylobacter is associated with many complications as well, right? Like Guillain-Barré is associated with, Campylobacter jejuni. If you give up, if the patient is in the ICU and you get a history of antibiotics, specifically clindamycin or cephalosporin, and the patient is coming to you with diarrhea, what is this? This is Clostridium difficile. And how do you diagnose Clostridium difficile? You will be doing stool toxin testing. You don't have to do stool culture. This is one of the very specific point I want to mention here. Don't do stool culture in Clostridium difficile. You will be doing toxin testing, anti-stool antibody toxin testing, right? Again, similar patient and coming to you with high-grade fever, like the fever is 104 now, and you can see abdominal distension in this case too. What is this? This might be a case of complication of Clostridium difficile, and that is toxic megacolon. And in toxic megacolon, most of the time we kind of have to do laparotomy, right? How do you treat Clostridium difficile? They can ask you specifically on the treatment of the Clostridium difficile as well. So remember that vancomycin is the updated guidelines now. Oral vanc is the treatment for Clostridium difficile. And obviously, if this Clostridium difficile is severe, then you can add IV metronidazole as well. So oral vanc plus IV metronidazole is the treatment of the severe thing, but generally you can treat it with vancomycin orally, right? But if a patient is a traveler and gets a bloody diarrhea, what do you think that is? That will be Entamoeba histolytica. They will be giving you this Asian states, most of the time Indian, in the visit to India or China, right? So Entamoeba histolytica can happen. What is the treatment for? What do they want as a treatment for Entamoeba histolytica? It's metronidazole, or plus you will be giving iodoquinol, right? You can give paromomycin as well. So remember this, metronidazole and paromomycin can be used, right? What if they give you case of diarrhea with cruise ships or like military people, military barracks or close quarters? So what you will be thinking? You will be thinking it might be rotavirus or something, but it's not in the adults. Rotavirus usually happen in children. Again, if you get a case with the military barracks, with the close quarters and cruise ships, it will be a case of norovirus, right? And obviously, if a child comes to you with less than 5 years of age with watery diarrhea, then it might be rotavirus, right? So you will be choosing rotavirus in that scenario, right? What organism what kind of organisms can be associated with bloody diarrhea here? Your Shigella. Shigella is associated with bloody diarrhea. EHAC is associated with bloody diarrhea. Campylobacter jejuni is associated with bloody diarrhea. Many of them. Again, this is a very important point I'm going to mention here. If you get a case of bloody diarrhea, like in the scenario, they will be saying bloody diarrhea, and in a child, there's a pain in the right lower quadrant. It's like appendicitis pain with bloody diarrhea. What do you think that is? That is Yersinia enterocoletica. That is very important to know as well. So appendicitis-like pain with bloody diarrhea, it's Yersinia. And if you get a case of bloody diarrhea again with reactive arthritis, then what is it? It can be Campylobacter, it can be Shigella, it can be Salmonella. Any of them. All of them can cause reactive arthritis in an adult, and not in child, in an adult. What if you get a case of diarrhea with Guillain-Barré syndrome? That is Campylobacter jejuni. And how do you actually diagnose Guillain-Barré syndrome? When you do the CSF analysis, and you will be seeing albumino cytological dissociation, like high protein with the normal cells, all of them, right? And also you can also use electromyography and nerve conduction studies to assess the GBS as well. Got my point? So Guillain-Barré with diarrhea is Campylobacter. Okay, let's talk about, so if a patient comes to you with chest pain and you see that this might be a case of cardiac ischemia, and obviously you want to evaluate. How do you evaluate cardiac ischemia? You will be doing ECG stress testing. That is the first line to assess cardiac ischemia. If you get if a case is cardiac ischemia, like you did the ECG and there is abnormal baseline ECG. So you can also do echo stress testing as well. Echo stress testing can be used as well. Again, case of cardiac ischemia, patient is a case specifically a case of cardiac ischemia, and the patient can't be able to exercise. What will we do? Then you can give dobutamine to induce this thing. You obviously have to induce the stress, so you will be giving dobutamine, and you do the ECG or echo, dobutamine EKG or dobutamine echo, right? This is how you assess the cardiac ischemia. What if your ECG, if you get a case with a pain in the chest area and whatever that is, and you see the ECG, and the ECG has diffuse ST segment elevation, what is it? That is a case of acute pericarditis. And how do you treat pericarditis? It's with NSAIDs. You can give steroids, or you can also give colchicine. It all depends on what's the renal function of this patient is, right? They can ask you this way as well. That the patient comes to you with the central chest pain, and it is worse when the patient gets in the supine position and better when leaning forward. This is also a case of pericarditis. They can ask you this as well. What if a case comes to you after a viral infection, a patient comes to you with lateral chest pain, and you can see the CK levels, they are elevated. What is it? This is a case of pleurodynia. This is one of the very important differential after the viral infection with the increased CK levels. So this is kind of intercostal muscle spasm. You need to remember it. If you get a case in which ECG is showing ST segment, anterior ECG reads like V1, V2, V3, and V4. They are showing ST segment depression, not elevation, depression. What is it? This is a case of posterior MI. These are reciprocal changes you are actually seeing. So ST segment depression is posterior MI, ST segment elevation is anterior MI. What if you see on ECG, you see a case of electrical alternance? What is this? This is a case of pericardial tamponade, or it can be pericardial effusion, right? Again, if you check the pulse in a case, the pulse is paradoxus. What is it? There's a drop in the systolic blood pressure more than 10 millimeter with inspiration. That's pulsus paradoxus, right? What's the differential of that? There are two you need to remember for your exam. Cardiac tamponade can cause pulsus paradoxus, and severe asthma. These two. Very important. Okay. You get a case of Baxtriad. What is Baxtriad? Hypotension, muffled heart sound, and jugular venous distension. What is it? This is a case of pericardial tamponade. And how do you treat pericardial tamponade? You will be doing pericardiocentesis or pericardial window, right? So before doing pericardiocentesis, you kind of have to do echo first. So remember this. In question stem, they can give you both. Like they will be putting a case of a cardiac tamponade, and in the answer stem, they can give you echo and pericardiocentesis both at the same time in the same question. So first choose echo because you have to do echo before pericardiocentesis. Very important to know, right? Okay. So if you get a case of pneumonia, community-acquired pneumonia, and you check the X-ray in these cases, and there is bilateral chest X-ray infiltrates both of side. What is this? Bilateral infiltrates. You will be getting a community-acquired pneumonia with bilateral chest X-ray infiltrates. That is mycoplasma pneumonia, right? If you get a case of community-acquired pneumonia with lobar pattern, like the patient have lower lobe consolidation or lower lobe dullness to percussion, then what's the organism here? Mostly strep pneumo. They want you to know strep pneumo is the answer in lobar pattern pneumonia. Again, what if you get a case of community-acquired pneumonia with lobar pattern, but they say interstitial now. Interstitial and similar lobar pattern. What is this? This is mycoplasma, not strep pneumo. Whenever they talk about interstitial, go with mycoplasma here. Right? What's the treatment? In empiric treatment, if they want to talk about, I will give you one antibiotic in the empiric treatment you need to remember. That is azithromycin. Right? And treatment for these pneumonia on the patient, already patient on antibiotics for past 3 months, you can give fluoroquinolones over azithromycin. So already if the patient is taking antibiotics for a long time, you should give fluoroquinolones, not azithromycin. Very important. And in old age too, you will be giving fluoroquinolones, not azithromycin. Pneumonia in a cystic fibrosis patient. If this cystic fibrosis patient is less than 10 years and the patient gets pneumonia, what is this? This is, what's the organism here? Staph aureus. Not Pseudomonas, Staph aureus. After 10 years, if the pneumonia comes in a patient, after 10 years with the cystic fibrosis, then it's a Pseudomonas. Before 10 years, then Staph aureus. Right? If a pneumonia happened after a kid took influenza vaccine infection, after the old age people, like 60 years, they get influenza a lot too. So after pneumonia can happen. So what's the organism? Staph aureus. Remember this. Right? Pneumonia with, if they mention kettles, then it's Coxiella burnetii, Q fever. Pneumonia, if they mention birds, then it's Chlamydia psittaci. Pneumonia with, so rabbits can cause pneumonia. They can assess you with rabbits too. So pleurodynia is the answer at that point. Right? Okay. What if you get a case in which a patient comes to you with a whole leg swelling and pain and suddenly shortness of breath? What is this? This is pulmonary embolism caused by your deep venous thrombosis. Right? And what's the treatment of pulmonary embolism? To treat pulmonary embolism, you will be giving heparin before doing your CT scan. We will be doing spiral CT, but before that, give heparin. And how do you treat pulmonary embolism in pregnant females? Not CT scan. You will be doing VQ scan, ventilation perfusion scan. This is very important to know. If a patient is already on warfarin and gets pulmonary embolism, what will you do? Then your next step is you will be confirming the embolism with spiral CT and put a patient on IVC filter. If you get a case in which already patient is on warfarin and gets a pulmonary embolism, put the patient on IVC filter. Right? What's the acid-base disturbance in pulmonary embolism? What happened in pulmonary embolism? What's the acid-base disturbance? You need to remember this. Because there is low carbon dioxide, pH will be high, oxygen will be low, and bicarb is normal. too acute to change in the pulmonary embolism cases. So the case in pulmonary, the acid-base disturbances usually is respiratory alkalosis, low carbon dioxide with high pH. It's usually respiratory alkalosis. What about asthma? In asthma, what happened in the acid-base disturbances in asthma? Again, it's respiratory alkalosis, low carbon dioxide with high pH and low oxygen, right? The bicarb is normal there too. But what happens in aspirin toxicity in the first 20 minutes? The first 20 minutes, what happens to your acid-base disturbances in aspirin toxicity? That also cause respiratory alkalosis, low carbon dioxide, high pH. In this case, the oxygen is actually normal and the bicarb is normal too. So low carbon dioxide with high pH is respiratory alkalosis. But after 20 minutes, what happens when you see a case of the aspirin toxicity and it comes after 20 minutes? Then this will be a state of mixed metabolic acidosis plus respiratory alkalosis. There will be low carbon dioxide, low pH in that case, and low bicarb. Right? So mixed metabolic acidosis plus respiratory alkalosis. How do you treat actually? What's the treatment of aspirin toxicity? Give bicarb. Increase the excretion through the alkalinization, give bicarbonate. And you know what else will be giving? What else is the treatment of as a bicarb? TCA toxicity, tricyclic antidepressants. You give the sodium bicarb dissociate drugs from your myocardial sodium channel. So very important to know, right? Your normal calcium is like 8.4 to 10.2. This is your normal calcium. And if the patient has a hypercalcemia, how do you treat hypercalcemia, by the way? If the case is, if you get a high calcium like from 10 to 12, how do you treat? You will be treating with normal saline. 0.9% saline, that's enough. How do you treat hypercalcemia if it's 12 to 14 now? You will be giving a normal saline only if the patient is asymptomatic. If the patient is symptomatic, what will you do? You will be adding bisphosphonate. Pamidronate is the treatment for hypercalcemia, which is symptomatic from 12 to 14. And what if the hypercalcemia is more than 14? Then what? Give normal saline and bisphosphonate. That's it. Right? If you get a case of high calcium, again, if you get a case of high calcium, and you, in the viginate, in the question, they will say that there's a polyuria as well. Polyuria with high calcium. What is that? Nephrogenic diabetes insipidus. Polyuria with high calcium is nephrogenic diabetes insipidus. And you know, high calcium with confusion is what? Delirium. Delirium can cause, confusion, and it can be due to high calcium. So hypercalcemia can cause delirium. What about low calcium? Low calcium, if the patient has low calcium or potassium, and you are given supplementation to like adding the calcium, adding the potassium, it's not getting better. Why? What's the reason? Because your magnesium is low. Low calcium or potassium, if it's not responsive to your supplementation, check out the magnesium. Right? If the patient has low calcium or low potassium and the patient is alcoholic, what's the cause of low calcium or potassium? Again, hypomagnesemia. Very important. Right? If you get a case of alcoholic, I'm going to finish it right now because this is going on for a while. I will be discussing this thing again in our next podcast. This is for now. I hope you get these high yield questions, high yield points. They want you to know when you are doing the question, just pick these high yield points and you can solve the question, any question you want. Right? So this is it. If you like the podcast, you can like it. And that's it for now. Thank you for watching.